I've already presented this data several times. The paper has been published last year in Bone, so I will sort of summarize this trial once again, because this is probably the first time this is done to this audience, and also I will present sort of a small extension study, because a number of the patients who have been treated in the randomized trial have been followed up and retreated with tocilizumab, and so I want to show you this data. This study has been funded by the French Ministry of Health, and the Chugai Pharma has provided the drug for free. So this is an old rationale to try to target interleukin-6 in fibrous dysplasia. It's been shown in this old Japanese study that IL-6 synthesis was increased in mutated cells. This study was done in 2 patients, actually, in the bone biopsies. And there's another study showing that using glucocorticoids to decrease interleukin-6 levels could improve mineralization of osteogenic cells from children who had fibrous dysplasia. So we have sort of this kind of rationale when we have started designing this study in the early 2010 years. And so we wanted to do a sort of a pilot study to establish the concept that inhibiting IL-6 could modify bone turnover in those patients. So we have run a randomized placebo-controlled trial, crossover trial. So what we are doing is comparing two sequences of treatment: 6 months of tocilizumab followed by 6 months of placebo, or 6 months of placebo followed by tocilizumab. So this is IV. For those who don't know this drug, because this is a rheumatologist drug, so this drug has been conceived to treat rheumatoid arthritis, and it's also used to treat giant cell vasculitis. And so this is an immunosuppressive agent, quite expensive, and patients may have also a number of infections when treated long term. So we enrolled 16 patients who were randomized to either of the 2 sequences of treatment. This is an intent to treat analysis. So at the end, we had 7 in the sequence toci, followed by placebo, and 6 in the other sequence. The main inclusion criteria, so these were patients who had been on bisphosphonates and were failing to respond to bisphosphonates in terms of bone pain, essentially. We did not want to treat naive patients because, again, this is an immunosuppressive agent, quite expensive, and in our mind, this cannot be a first-line therapy. So the patients had a VAS of greater than 3 at the most painful bone site, and they were adult patients. So the primary endpoint was the change in serum CTX, which is a marker of bone resorption, after 6 months of treatment versus baseline. And secondary endpoint were change in bone pain, change in P1NP, BAP, osteocalcin, ICTP, which are other markers, quality of life, and so we run an analysis of variance with sequence of treatment, period, and treatment as factors, and counting for a potential carryover effect, which is always an issue in crossover trials. So the baseline characteristics. So you see that those patients were in their 50s, more women than men, normal BMI, and these were, of course, patients who had their disease for many years. About a quarter of them had overt McCune-Albright syndrome. So patients with moderate or severe fibrous dysplasia. So the primary endpoint was not met, so clearly there was absolutely no change in serum CTX when we compare the 2 sequences of treatment and versus baseline. And if you look at the other bone markers, again, there was no significant change. If we look at bone pain, which was a secondary outcome, and clearly we are not powered to look at that, so this is exploratory. there was no significant difference, again, in those two sequences of treatment versus baseline. However, there were 3 patients that experienced a very important decrease in bone pain. And when we were still blinded investigators, we were really impressed because those patients were on bisphosphonate, had been on bisphosphonate. Some of them were taking opioids, etc., and they could get rid of opioids. And so, before the analysis, we thought that this would work. But only 3 patients, and of course this is, and well, the study was not designed to answer this question of bone pain because it was thought as a pilot study in bone turnover. So at this point, I will summarize this trial by saying that tocilizumab does not decrease bone turnover in FD patients when administered in patients who fail to respond to bisphosphonate. And maybe again, this concept of using this drug in those who are resisting to bisphosphonate is not a good one. Maybe we should try to in naive patients, I don't know. And tocilizumab does not reduce bone pain in most patients, but a substantial effect in the subset cannot be ruled out in this trial designed and powered for markers, but not for pain. So we had these 3 patients and who are doing well, and after a certain period of time, pain relapsed. And so we decided to retreat them with tocilizumab. So I remind you that the initial sequence, there was 6 months of treatment. Here we decided to do 3 months because, we are treating people off-label, etc. So 3 months, that's reasonably safe. So this is sort of patient number 1. Is a man in his 30s who has severe polyostotic, a lot of pain in the ribs, many fractures. And so when the disease relapsed, he had a VAS of something like 10. It was completely held by 3 months of tocilizumab, and he has received 4 courses over time, over several years. Again, so this is the individual trajectory of pain. Okay. So this patient is still monitored at this point. A second one who has sort of a relapse every 6 to 9 months, and so again he received 3 months of therapy over time, and again the individual trajectory of pain before after over 3 months. And this patient is a woman in her 50s, so she had only 1 relapse, and it was not necessary to treat her again. There's another patient who was treated in France, in Bordeaux, who hasn't been enrolled in the trial, but we have treated him open label. He had been on denosumab before with good result and then relapsed, and is doing very well this. So I would conclude that clearly tocilizumab does not influence bone markers, but a number of observations from the randomized trial and from the follow-up of these patients post-trial are consistent with a sizable reduction in bone pain in a subset of patients. And so now the difficulty is to do a new trial in a different kind of population who have pain, maybe who would be naive of bisphosphonates, we don't know, and clearly with bone pain as a primary outcome. So finally, I want to acknowledge all those who participated in this trial in our INSERM unit and at the reference center, and of course the funding. Thank you very much for your attention for this first talk, and I will turn to the second one, unless there's a pressing question. Yes?
I think it's a pretty obvious question. Do you see anything special about those 3 patients in terms of baseline IL-6 levels, severity of the P, or anything that could hint towards why they responded?
So we've looked, of course, at all the baseline characteristics, and I must say that I'm not able to distinguish, to identify what could be a predictor of a good response to IL-6. I must also recognize that there are only 16 patients, and so to do such a predictive analysis is quite difficult.